we really haven't had an opportunity this scholars program yet to get into issues that relate to quality of life. So today we thought it would be a good session to be able to do that, since we have people from nursing home care, from home health, from academia, from hospitals, and from a few other settings that I'm missing. And so all of those things fit into quality of life, and probably many of you are aware that there are a lot of grants and programs now on two issues. One is on quality of life, and the other one is dissemination of information on quality of life. So I thought these were particularly relevant concerns. We also did our horseshoe again, hoping that we could have some good discussion, and Dr. Paunovich encourages discussion throughout her presentation. So we thought that this might facilitate it, and as quality of life issues come up that relate to your profession, please feel free to jump in, because I think that could really add to the program. So our brave speaker today is Dr. Eleonore Paunovich. Maybe many of you know her. She is a faculty geriatric fellow with our GREC program, who many of you know from the GREC over at the VA. It's kind of a combined program of the VA and the Health Science Center. Dr. Paunovich has been on the faculty before, and then kind of took a break and was in the Air Force for 10 years, and then came back to join us as a faculty fellow. This is her second year in that program. She does both clinical and academic work, helping supervise nursing care in some of the nursing homes, as well as teaching our senior dental course in geriatrics and oral health. And she's been a busy person, and we appreciate her punting today, and her presentation will be on geriatric oral health and the impact on the quality of life, institution versus homebound. So Dr. Paunovich, your turn.
Thanks, Ruth. I know you're all waiting to hear of physical therapy, and I'm going to present to you a form of physical therapy, oral health. I think by the time you walk out of here, I know it's like, who really wants to talk about oral health concerns right now when you're geared up for physical therapy? But what I hope to do by the end of this session is basically show you how good oral health really is an aggressive program that is very comparable to physical therapy, and it really has the same goal in mind, and that's the patient's overall well-being. And when we think of the patient's overall well-being, if we look in today's literature in medicine, in nursing, in pharmacy, in all the healthcare providing fields, social work, psychology, anyone who's involved with geriatric healthcare, we see a topic that is constantly coming up on the horizon, and that's quality of life. And I think that the medical profession, quality of life is not a terminology that is new. It is actually a very old concept that was originated back in 1947 by the World Health Organization. And the description of what quality of life was the overall well-being of your patient, the general life satisfaction and overall well-being of a patient. That was a really nice package, and from that we saw a lot of the holistic medicine evolve back in the 70s when it became very in vogue. You know, we had holistic medical care, and the concept was that you treat the body as a whole and not fragmented in parts. Somehow we had a lot of quote-unquote charlatans that were associated. I'd hate to use that word, but holistic medicine really got thrown off to the side. It wasn't really the vogue at that time, and this is when specialties, there was no way you could know about everything about a person's health, and it got fragmented into specialties, and that's what brought the onslaught of all the specialty training programs that we have, not only in medicine, but we see it in dentistry and many of the other healthcare providing fields. I know physical therapy, they're specialized now. You have specialists for vision, specialists for the musculoskeletal system. In pharmacology, we see specialties. Geriatrics is becoming one. Clinical pharmacology versus academic pharmacology. And in the world of specialization, there's been a cry for help by our patient population. With the beginning of the patient advocacy offices that we see around hospitals, medical centers, we've seen an evolution of a underground that's really becoming superficial now to our eyes, and that is that patients are voicing their concern into, one, how they're being treated, their diagnosis, and their management. And many of them are waving their hands and saying, wait a minute, I don't want this type of treatment. How many of us have encountered the living will or do not resuscitate orders? When you think about it, what are these concepts really telling us? The patients are telling us we want to have control in our life with our health care, if we're going to continue with our life. They've put a definition on quality of life. But how many times have we really stopped to listen to what their subjective feelings are about their disorders? They have pain. We listen to their pain. We want to diagnose their pain. We want to treat their pain. But how many times do we think of how that pain integrates with other parts of their overall well-being? So those are some of the thoughts that I wanted to interject before we go and look at quality of life. And as a dentist, our profession is extremely involved right now in trying to evolve this quality of life concept into the overall well-being of our patients, and we're trying to integrate our treatment of the patient and how that impacts on the overall health of the patient. Now, when Dr. Saunders was here with you all, I think some of you had your eyes opened to how oral health really does impact on your overall patient. With the regimen of working with their mental status, their physical problems, their financial problems, we sort of lose sight to their oral health. And we've been in a lot of nursing care facilities where oral health care just hasn't ranked up there. And what I'd like to do is present about 15 minutes of some of the oral health concerns, and this is why I have this article for you. It's not a scientific article. It's a nice article that talks about some of the concerns that our older patients have, and it's written in such a language that I think it's understandable to everybody, and it's really a nice reference article. But since you haven't had the opportunity to read this, and I'll have you file it away and you can look at it at a later point, let's just consider what are some of the oral health concerns that you see in your older patients. As you're working, what do you think is the number one oral health? Think of yourselves. And when we think of ourselves, we can translate that into geriatric care with a little different twist. What are some of the oral health concerns that you think, or you know that you think of your parents?
Ill-fitting dentures.
Okay, ill-fitting dentures. So we have dentures. What else? What do they complain about? What are they afraid about? What are you as healthcare providers, if that is your field, what are you concerned about that patient when you think of oral health? Infection. What else?
Hygiene.
Okay. I'm surprised that no one's mentioned it because it's the number one reason why no one likes to go to the dentist. Pain. Right? That should be number one. So we'll just make it real obvious. Believe it or not, we've hit the four main concerns in a nutshell. Pain is a number one concern, and that's mainly because how many of us, as busy as we are in providing, if you are in a healthcare facility, a nursing facility, convalescent home, an acute care facility, patients in pain take a lot of time on our part because we have to get the proper individual to go ahead and take a look at the patient to make a diagnosis, and then we have to think about treatment. The infection it's a potential risk factor in that people can die from dental infection. It doesn't happen often, but if you have an acute abscess in the back areas of the molars where we have our molar teeth, and the infection goes untreated, and we have the soft tissues that enlarge, and they can actually compromise the airway. A patient can basically die from an infectious process indirectly, okay, as a result of swelling, edema, and those type of things. Oral hygiene, why is that so important? Why do we get up and go through a regimen of brushing and flossing our teeth every day? Okay, okay. We want to keep disease away, so you want to prevent disease. And aesthetics, the way your teeth look. No one likes to have a bunch of black spots facing when they're talking, having lunch with their friend, when they smile or when they talk. What else?
Nutrition.
Okay. Okay, your overall well-being. Okay, overall well-being, oral health. We're concerned with maintaining proper oral health because we want to maintain the tissues. Our mouth is part of a whole being. And that mouth is composed of all of the major systems in our body. We have the neural system, we have the vascular system, we have the digestive system. All of these integrate into as from the oral cavity. So when we're thinking of oral health, if we have good, clean, healthy oral tissues, we're fine. As soon as oral tissues become compromised because we don't maintain proper hygiene, what type of things can happen? They can develop, if we have poor oral hygiene, we can develop things like tooth decay, periodontal disease. And if these things go unaddressed with our patients on a long-term basis, what can happen? I've got a couple of dentists in the audience, and I'd like you to help me since I'm ad-libbing this afternoon. We have other processes that occur with this compromise in oral health. Rose, you can help also. She's sitting there thinking. If a patient has tooth decay and they have pain as a result of the tooth, it doesn't have to be the throbbing type of pain. It can be pain when they drink something cold. A sensitivity to cold is usually one of the first signs that they've got a tooth problem. If they have that sensitivity, think of yourselves, if you've experienced sensitivity to cold, like chewing on an ice cube, which we're not supposed to do, but some of us do, or eating something really cold like ice cream, and if it hits the tooth just the right way, it can really zing you. And that can be very, very uncomfortable. Can you imagine how a debilitated, fragile person who's laying in a bed or a wheelchair and they're eating their lunch, and having gone to many nursing facilities, I have found that the highlight of many of our older patients is their meals. This is where they get their social interaction for the day, they get their nutrition, but the main thing is the social interaction with their peers. It doesn't matter if we're going to a nursing home. I visit many homes. I do homebound dentistry, and Meals on Wheels is the highlight of the day of some of the residents that I visit. You know, so eating is number one priority for a lot of our older patients, a highlight of the day, not only from the physiological benefit, but from the sociological benefit also. So if we have a patient who has pain, who has a sensitivity, the number one thing is they're not going to be able to eat. So now when we start to think about quality of life and overall well-being, how does that not being able to eat affect them overall? Do we take time to really think about that? The fact that they have pain when they eat, or they're sensitive when they have something cold, and in many programs where they're not getting hot meals and they're getting cold fluids and that type of thing, they'll develop an aversion. They'll say, well, I know I can't touch that juice because it's cold and it's going to hurt my teeth every time I drink it. So they're not going to be drinking their juice. So all of a sudden we end up with a nutritional compromise. They're not going to have their juice, which has a good source of potassium and all the other. Do we have any nutritionists here that can help me? Vitamin C, okay. we have a lot of essential vitamins and nutrients, leafy vegetables, salads, our green foods. All of a sudden, our patients do not ingest the proper foods because of the pain, the problems in their mouth. And then we start to have patients that have not only oral health problems, but they start to kind of shine away. They complain of digestive problems, and a whole gambit starts to roll here. So the point I'm trying to make is that the mouth is really the window to the patient's overall health and psyche. If the patient's highlight of the day is eating with their friends in the cafeteria area, and they cannot eat because of pain, because of the presence of infection, they're not going to have their social input, which will make them feel good. They're also going to lose out on the nutritional aspect. So that's a problem to consider. The other thing is aesthetics. As we get older, and there have been a lot of studies done in the sociology area and the psychology areas, where they really look at what is important to the aging population. What are things that our older adults, and I'm talking about 65 and over. There have been numerous studies that have been done. The most recent is by a man and his group, Spiker. They're out of the University of Connecticut. And this study was done in 1990. And what they did, they actually went to nursing homes across the country, and they did an evaluation of what is important to you in your life. What do you think the number one ranking priority for 65 and over population was? Good health. Good health in general, okay? Good health. They wanted to have mobility. They wanted to be able to get to where they want to go. So good health was the number one. The second one, what do you think was? Somebody said it, appearance, how they look. Because why do we take the time to get ready in the morning? You know, we primp if our hair doesn't look right, you know, or our tie isn't straight, or the tie's not the right color to the shirt, or our shoes don't match our outfit. Why do we take all this time? Because we feel good when we look good. And so some people, if I took a survey with we have about 25 people here in the room, you would have a different ranking and priority of what looks good. Some people may think it's their hair, some people their clothes. A lot of people feel that their teeth are, you know, when we talk to people, where's the first place we look? We look at their faces, we make contact with eyes, and then we listen when we talk. We communicate, we thrive on our communication skills. How many of you focus in when you talk to someone on the people's eyes? How many of us do that? Okay, after we check out overall body appearance, right? Okay. After we focus in on the eyes, what do we focus in on? Their oral cavity, their mouth, especially if you have a hearing disability. You know, you're going to focus in on the mouth. So if you can imagine a population of older patients now who have some hearing deprivation, they don't focus on the eyes like we normally would. They start to focus in on the mouth. So the mouth becomes very important for communication skills. And this is the whole basis of their psychological and social support. So if they have bad-looking teeth or no teeth at all, how many of you have seen people who are embarrassed by their look and they're kind of like this talking all the time? Okay? Well, when you're old and you can't hear real well, you can't communicate this way. So what's the first thing that we see happen? These patients withdraw. I had a wonderful example about 3 years ago, over in Biloxi, Mississippi. That was my last Air Force assignment. And I had a patient, I was doing hospital dentistry at that time, and I had a patient who came in. He was Mr. Reichman. He was a retired colonel. Well, as a young major, retired colonels are intimidating, and especially being a female officer, he thought, you know, he was going to just roll right over me. He was the meanest individual I have ever encountered. It was this authoritative disciplinarian figurehead that was just very strong. No matter what we did for him, he'd come in, and I had a young airman at the desk who was a receptionist and would take all the patient paperwork and all. Mr. Reichman would bark at the poor airman, and the whole office just cringed when we knew that Mr. Reichman was coming in. You've all had people like this that you just don't look forward to coming in because they're a real pain, especially on a day when you're busy, you're having problems, you're not really feeling 100% about interacting with people, and then a Mr. Reichman comes in. We've all had our Mr. Reichmans. Well, he needed extensive dental work. And he came in because his wife made him come in, not because he wanted, but his wife said that he had the ugliest smile. And the retired military population, if any of you are familiar, they thrive on their social circles of going to the club and having dinner and dining and dancing and all of that. Well, Mrs. Reichman became very, how should I say, disgusted by her husband's appearance, which he kind of looked like Gonzo, you know, from the Sesame characters. You know, he just had a very, very ugly smile, if you want to call it a smile. Well, anyhow, so are you getting a picture? This is hard to do without slides, so if you can get the picture, I think we're doing okay. Now, Mrs. Reichman's concern was that we had to make her husband look better. His concern was getting him back out in time to hit the golf course. So he wasn't really concerned about sitting in the chair. As I said, disposition very bad. Well, we started with his treatment, and it became harder and harder every week. He had a long treatment plan. It required about 8 visits. By the 4th visit, I was ready to pull all my hair out because he'd just walk in, and I just tighten up and cringe. I'd say, oh, he's here. Well, all of a sudden, I found out in talking with his wife that he was they lived in a retirement home, and apparently the entire 320 residents of the home had the same feeling when Mr. Reichman walked in. They'd cringe, they'd hide. He had no social interaction with the people whatsoever. I find out that when his wife went to the club, she was a social butterfly of the family. He just went along because it was his husbandly duty to do so and keep her happy so he could be happy at home with his meals and have his laundry done and all of that. So the situation was rather interesting. Well, it amazed me that a person like his wife would have such social, outgoing personality, and here her husband was kind of the stalwart of it all. And as we started to work with him, he had no teeth. The few that he had were gone. And all of a sudden, he had some teeth. At the end of 7 weeks of working with him, he had teeth. And he looked extremely handsome. All of a sudden, we went from Gonzo to, you know, he could have been on Geriatric GQ, you know. He just looked really, really good. And about 3 weeks after that, Mr. Reichman comes up for his post-op so we could see how he's doing. And I had a total reversal of the individual. He didn't come in grumbling and howling at us. He actually brought me a basket of fruit as a peace offering for his ugly disposition. And we sat down and we started to talk, and he said, you know, I felt so bad about myself that I just didn't want to react with people. He had such a negative image of himself because of his mouth that he was doing things because his wife wanted him to do it to make her happy, but he wasn't happy. His overall well-being was just totally ignored. And I asked him, well, why didn't you go to the dentist earlier? Well, you know, his priorities were different in life. And he never realized that changing his aesthetics, his smile, would have such an impact on his social and psychological outlook. So I think we've all seen people like that, and I'm sure my peers in here have all encountered the change that comes in with aesthetics. Disease prevention, the oral cavity is a mirror of the body. Healthy tissues means that your digestive system is working well. We can look as clinicians, as dentists and our dental hygienists, we can look in a mouth and we can actually pick up things like nutritional deficiencies. Remember the patient that has pain that doesn't want to eat? These people then will develop more pain. They may complain of burning mouth, burning tongue. And many burning mouth, burning tongue disorders are signs of certain clinical systemic problems that are going on. Nutritional deficiencies being the number one. People with a B12 deficiency, a niacin deficiency, actually all of your vitamin B category, end up having symptoms of burning tongue or burning mouth. Patients that have diabetes will complain of burning mouth, of burning pain. And diabetes is really interesting. I really didn't realize, and maybe someone here is more learned than I am in this area. I just read some statistics a couple nights ago that 12 million people in this country have diabetes. 10% of patients that are 65 and older have diabetes and don't know they have it. That's a large number. That's a large number. Now, these people in that population of adults that can have adult onset of diabetes, and that's becoming more and more prevalent now because of the eating styles that we've had with the cholesterol, triglyceride problems. I think they've been showing some associations between that and adult onset diabetes. Many of our patients that we see at the dental school, the dental students and the dental faculty pick up that they have diabetes before the patient knows they have it. We can look at the health of their gums. We can smell their breath. They'll have a distinct odor if they have diabetes. They can complain of sensitive gums, burning mouth, burning pain. So diabetes is another systemic problem. People with Crohn's disease, people that have the arthritides can have connective tissue disorders that we can see in the mouth. People that have skin disorders like lichen planus, pemphigus, pemphigoid, those can have oral manifestations. And what's the number one big thing in the mouth that we really want to make sure that this population doesn't have? Cancer. Oral cancer. I don't know, maybe Dr. Mohammed knows exactly what proportion of the population, but there a good significant number of people 65 and older. Do you have an idea of percentage on? A significant number of the oral squamous cell carcinomas, 35? Yeah, it's higher than the average for the younger person. I'd say what, about maybe 30%, 35?
The average is about 3 to 5%.
Okay.
60 and above.
Maybe 10, 12%, somewhere in that neighborhood. Okay, so you have an increased incidence in oral cancer in your geriatric population. And having been a hospital dentist, I can tell you that oral cancer in an older patient, especially when our immune system starts to shut down, our vasculature starts to shut down, our proximal circulation decreases, our capability to respond to treatment is not as great when we're older, and we all know that dealing with geriatric patients as it is with the young adult. So managing oral cancer becomes a problem, and it has a whole host of problems. So our problems that we're looking at in our well list with disease prevention include not only systemic disease and identification of it, but oral cancer is included in that category. Now, how does this all impact with quality of life? We know that have I converted anybody to believe now that the mouth is a mirror of the body? I mean, can you see the importance? The physical therapists, are you a little bit happier that you're here this afternoon? Okay. The idea that I'm trying to get here is that dentistry for many years has been placed sort of on the bottom in nursing homes, in long care, acute facilities, chronic facilities, acute care facilities. And believe it or not, I think that we can have a very strong impact on how your patient responds to the treatment regimen that you're proposing for them, be it a physical therapist, being a physician, being a nurse, being the nurse's assistant who's trying to make this patient compliant. And I just hit the right word, compliancy. That's a problem with our patients, right? They're non-compliant many times. Why?
Sometimes I don't know if they think it's really necessary. Perhaps they can't see or feel well enough to floss their teeth. They do not feel well overall, so they let that go.
Some of it's cultural.
A lot of it's cultural, right? It's like, well, my parents were in dentures when they were 25, and I'm 60 years old, and I still have half my teeth, so why should I worry? We've heard that, right? Compliance is a major problem, and now I'm going to talk about compliance in general in healthcare delivery, not just in dentistry, but in the number one is in medication. compliancy with our patients taking their medications. We were just in a nursing home a couple weeks ago doing some treatment on residents, and we had a patient who was a terminal cancer patient who had a heart murmur, and we were going to do a cleaning on her teeth. And in order to do the cleaning on her teeth, we have to give her antibiotics to protect the damage to the heart so that we don't get what we call endocarditis. She refused the prophylactic medication because she had had enough of swallowing pills and shots. And if you look at her health record, that's all that she was doing. She's terminal, she's going to die, she doesn't want anything else. We see this a lot with our patients who have terminal disease, but we also see this a lot with patients now who are in long-term care facilities. They just get tired of seeing the doctor, getting prodded, getting poked, taking pills. And the whole quality of life issue now has really started to look at, okay, this is what we, the healthcare providers, should do for your problem. But how do you feel about it? How do you feel about your problem? Is your pain so bad that you can't, walk to the store? What's important to you? How satisfied are you with your life? What's important to you to do? Is it important for you to be able to run around the block? Or are you satisfied just by walking? Then maybe we don't have to address the knee injury that you have. If we start looking at procedures, and the people who've done the most research on quality of life and looking at subjective issues are people that deal with arthritis. If you look in the arthritis literature and in the drug therapy literature, you'll see a lot of quality of life material. And what we're doing now in medicine and in dentistry is that we're saying, okay, now, ideally, how many people think that if you don't have any teeth, the patient needs dentures? Having no teeth is regarded as a disability. Am I right or wrong? Do we regard that as a disability? Why do we regard it as a disability? Okay, texture of the food changes. You can't chew the foods that you normally could chew, right? What else?
Social and psychological.
Okay, the aesthetics, you don't have teeth. Some of us find it socially objectionable if we don't have pearly white Madison Fifth Avenue, advertisement smiles, right? The fact that I have a crooked front tooth, does that bother anybody here? You're not going to tell me anyhow, right? But how many of us really focus? Is it important to me, that I have a crooked tooth? No, I've got other priorities in my life right now. Maybe one day I'll fix it, okay? But when you think of it, what I think is right or what you think is right may not be what you think is right for yourself. And dentures are a good example. We get calls all the time. Our patient doesn't have dentures. They need dentures. Well, why do they need dentures? First, do they want dentures? A dentist who comes out to make dentures or partial dentures for a patient that doesn't have any teeth, if that patient does not want those teeth, by golly, they're going to be the most miserable people you've had because they're going to chronically complain about they hurt, I can't eat, I can't chew, and you're sitting there wondering, well, they've got teeth now, why are they complaining about these things? What I'm trying to get across is that having no teeth is a disability, but we have to take that disability, like other disabilities in the body, in the perspective of that patient. And what's important to that patient? Some of us say we need teeth to chew. True, we do need teeth to chew, but there are a lot of people out there who have overcome that loss of dentition and can actually gum their food better than some people can chew that have teeth. We've seen this. You've seen these type of people. And I'm using the denture as an example, and hopefully you can transcend that to disabilities that you're dealing with. But then we run into other problems. Okay, we can't chew the foods that we want, but what goes along with that then? Taste. We acquire a different taste. Now, is it important for you to taste your foods? How many of you have sweet cravings? I heard somebody in here talking about how they were giving up for Lent sweets, right? Okay, that's really difficult, but why is it difficult to give up sweets? What is it about sweets that make them so important to you? Right, because you shouldn't have all the time because that's going to give us a weight problem. It's more empty calories. I hear this all the time, empty calories. Okay, but they're pretty tasty empty calories, aren't they? But what is it about sweets? How many of us crave chocolate? Any chocoholics here? Okay, some of those that are shaking their heads just can't understand this, but I'm sure you have your own vice. How many are connoisseurs of chocolate? Does it make a difference if you have a Hershey's candy bar or you go and buy a Cadbury's candy bar, or you're really going to splurge and go to Godiva and get some Godiva chocolates? No, as long as you have chocolate, it's that taste, right? Now some of us just, but what is it about the taste? What is it about the taste of chocolate? It makes you feel good, those of us that are chocoholics. That's how we get our little rush. I'm sure we have our coffee people. Coffee maybe makes the taste of that food makes you feel good. We all have those. And I think it's important to realize is that someone's probably sitting here saying, this woman's crazy. What is she talking about? Chocolate and taste. But it's true. When you think of food and you look at the taste studies, each of us will, if I gave everybody a chocolate bar, you'd all describe it differently. Some of you will eat it, just swallow it like I do usually. You know, I inhale it, I don't chew it, so I don't really taste it, and that's really empty calories. But each of us gets our own different little pleasure. And the point that I'm getting around is just like that denture. What's important to you, is it the taste? Is it being able to chew foods? Or is it the way you look? They're all different, and they're all different to people. So when you're doing your treatment planning and we're providing health care for our patients, when we're doing physical therapy planning, when we're doing medical treatment planning, we really need to look at the patient as a whole, look at our objective clinical symptoms, but then take a look at the patient and see subjectively what is it that they want out of the health care. And this is what brings in this quality of life concept. Now, in medicine and dentistry, medicine has, since about 1987, been working on quality of health, quality of life models. Are any of you familiar with what I'm talking about, these models? Okay, I'm going to put one on the board for you, and what you're going to find out now is that what I'm actually describing to you is a team concept. We can't just take a patient and say, okay, you've got heart problem, hypertension, or congestive heart failure, so the cardiologist is going to take care of you. You've got a visual problem, so you're going to go down and see someone in audiology or maybe work with a physical therapist. You've got a mean disposition like my Mr. Reichman, so you're going to go see the social worker and maybe even the psychiatrist, right? Well, all of us really have to work as a team, and I really don't think this is just in geriatrics. I really think it should be in overall health care. And maybe our First Lady Hillary Clinton will look at this model and incorporate it into our overall health care plan. But what we're really looking, oops, and I put politics in this, and that's a no-no, right? Okay. Let me just get this so I give you everything that I have in my model. Okay, at the center of the model is our aging physiology. From the day we're born, as we age, we find that our body is physiologically and biologically adapting every day to changes and stimuluses in our environment. So we have aging physiology, and associated with this is a degree of disease morbidity. We eat too much chocolate. We gain weight, we can't run. Our cholesterol, the good cholesterol goes down, the bad cholesterol goes up, and we're a mess, okay? Now, based on what we've talked about, there's 4 areas that really evolve around our aging physiology concept. What are they? The number one thing we talked about was social function, right? being able to socially interact with people. Many times, and I find this when I look at my parents a lot to understand aging and what's going on. I'm sure that you've all have done this. I remember as a child, my parents were basically like what I'm doing now, busy with work, busy raising a family, and social interaction was usually a consequence of the job or associated with the job. And because we're so busy trying to maintain our livelihoods, many of us find ourselves in a situation where we don't have that time for the social interaction that we would really like to have. So it's mainly, peers at work or that type of thing, but it's not to the extent that we see as we get older when our priorities or our responsibilities shift. When we're no longer out there, what's the biggest problem with retirement? The biggest problem with retirement. Any social workers in here that can help me? Social isolation. Here's somebody who had responsibility, they had to get up in the morning, they had some responsibility no matter what, they fit into a piece of a big puzzle and they felt good about it. All of a sudden now that puzzle doesn't exist for them anymore and they sit there and they wonder, well, what am I going to do today? And this is where depression hits in, and all sorts of psychological problems can actually set in because these people feel isolated. They don't have that responsibility like they had anymore. Think of it when we change jobs. How many of us have been in a position where we were running a section and then all of a sudden, and we see a lot of this today in the industry, like in the defense industry, all of these big high-powered defense contractors. Here we had a lot of white-collar workers, and all of a sudden there's no more money, no more wars to make all these fancy airplanes and equipment and weaponry with. And now look what's happened in California and on the East Coast in Massachusetts where high-tech was a real big part. We have a lot of people who don't have that responsibility. They don't run a division, they don't run a department, and they're having a hard time coping with it. They're not making the money like they used to. And that's another point. When we retire, what happens? Our economic levels sometimes are shifting. When I can remember hearing my dad saying, oh yeah, Social Security is going to take care of me when I retire. Well, my dad's retired and Social Security is gracing him with $600 a month. How far can $600 a month take? And we're all involved with this with our patients. How far can they get along with that? Many times if they've got cardiac problems or other medical problems, their medication alone can run a couple $100, if not more, a month. And they have to live, maybe they have homes. And that's been the hardest thing when I look at homebound patients, is actually looking, are any of you involved in a homebound healthcare program at all? You all really need to look into the community and see what's being done, because these patients are the ones that really can't afford to go into our long-term facilities. These are people who are economically really strapped, and I have not seen economic strapping until I visited some of these homes and the horror stories that exist in the community for our older people. I think it's a shame that in a country of our wealth, and I don't want to get on my soapbox here, but I really struggle when I go to see these patients for a couple of days after I see them, and I think about them and the situation of how they're living. And many of them live in conditions that people who have pets live in better conditions. And I'm not exaggerating here, it's really sad. And I think that when we look at social function, we have to look at the integration of all of the members, and this is where homebound versus institutional becomes an issue then. Okay, so we have social function. Then what's another part that's associated with overall quality of life? I really haven't talked about this too much. Cognitive function. If you talk to a psychiatrist, you're going to find that anywhere from 12 to 14% of the population, 65 and older, has some degree of dementia. How does that impact on us? How does that impact? How does impact and dementia impact on us as healthcare providers?
Well, you have
Okay. Well, the one impact is on the self. The self is not capable of taking care of themselves. The second impact is the healthcare provider. Is a person capable of following instructions, following healthcare regimens that you give them? Do they need to be exactly, okay, so cognitive functions are a really critical part to looking at overall quality of life. How many times have we seen treatment plans where cognition is not part of the treatment plan? No one's evaluated the cognitive state, the mental status of the individual. And that has a big impact because, and let me share it to you with dentistry, this is an area that's totally new to me. Coming into the fellowship, I've been thrown into it, and I wonder how I practice dentistry. I had a private practice before going into the military, and I think of all the geriatric patients that I had. How many of us have had a 75-year-old patient that we're providing counseling, guidance, or treatment for? And you go through your whole spiel of this is what you're going to do, the medications you're going to take, or this is what physical therapy, this is what you're going to do. The patient comes back to you after a week or so, and they haven't followed your instructions. We've all had those patients, haven't we? And how many times did I go, oh, that person's old? It's the attitude that we have. What we don't realize is that there's that 10 to 12% that as we get older, some of our brain cells or the neurons don't synapse completely, they don't fire completely, so we get forgetful, memory loss. That's one of the first things that we see. And we don't take the time to realize that that's a handicap, and it's not the patient that's at fault for being non-compliant, it's our fault. When we give instructions, do we know that that patient's listening to us? First, can they hear? Second, are they listening? And there's a big distinction between hearing and listening. And how many of us take the time to really figure out? There's a real quick way of assessing mental status, and it's called the Folstein, the mini mental state. It's a 20-item questionnaire that you actually go through with the patient, and a quick score will let you know, do they have a dementia? When we talk about informed consent, that's becoming something that we have to do. Did you know that in some states, informed consent cannot be obtained from a patient if they're demented? If you have a demented patient and they sign that informed consent, you're doing something that's not legal. A legal guardian has to do that. So you need to look at your state regulations. So informed consent's an issue here with cognition. So you've got cognitive function, and then we have affective. Anyone know what affective implies? What do you want to put under this category? Okay, their moods, their frame of mind, the psychological stuff, okay? That all goes into the affective. How they feel about themselves and how they're going to interact because of how they feel about themselves. My Mr. Reichman became the president of the residence home after being, they almost wanted to kick the man out, but he felt good about himself all of a sudden, and he became a very amiable person, and it was a total reversal of his personality. So many times when we think that people have personality disorders, we need to look a little bit further. Why do they have that? Is it something about themselves that they're not sitting well with? How many of us, some people are, we say have personality, they maybe withdraw, but maybe they're withdrawing because they've got a little handicap or there's something about them and they've been ostracized and they just have had enough of that, and they don't want people to stare, they don't want people to make remarks, so they withdraw. But then they're labeled, recluses or whatever word we give to these people who just isolate themselves. So affective function is basically all, this is where the realm of the psychiatric people really has a strong input, and it all ties in together. And the other part is physical function. So if we look at overall quality of life, we want to be able to integrate these 4 areas. How mobile we are. A person who, I remember about 4 years ago, I tore a ligament in my knee and a hole in the disc of the knee, of the meniscus. And I wasn't playing football. I was at my desk and I got up to answer the phone and I was in sneakers. You never wear sneakers in your house on carpeting because I learned the hard way. I turned around to answer the phone. My body went that way. My knee and leg, lower leg, stayed put. I had to be in a cast for 4 weeks. It was painful, but the immobility drove me batty. I couldn't get in. I lived in a 2nd floor apartment. I had stairs to handle with. You know, we don't realize how important physical function is to our lives until we become handicapped ourselves. How many times do we go into, finally now we have regulations and federal laws that are saying that institutions have to have access capabilities for peoples in wheelchairs and walkers and that type of thing. But if you think of your physical layout where we work, are we really equipped for some of these people? I know a lot of dental offices aren't. I've been in medical clinics that aren't. You know, I think we have little handicapped parking signs, you know, that we put up, and that's about the extent of our handicap services. And I think that that's something that we really seriously need to look at, because if you've ever been physically compromised, you'll know exactly what these problems are. And if you think of a fragile, feeble individual who's trying to come out to your office for care, or even in your nursing home facility, now that, I think nursing homes are probably the best that I've seen as far as being equipped to handle these people naturally. But any other offices are not that I've been in. And I think that's something we need to consider, and that goes under physical function. Now, if you look in the literature, there's all sorts of tests. Physical function, they have what they call activities of daily living. That's the most commonly used, and many nursing homes will use this, and it's a little physical functioning report. How does a patient take care of themselves? Can they groom themselves? Can they go to the toilet? Can they eat? You know, we look at the basic functions of living and to what extent they can perform them. So activities of daily living and those types of assessments have been made. For cognition, we've got the Folstein. Social function, if you take a look, we have the McManus questionnaire is probably the most utilized. It's a social impact questionnaire that looks at how the person interacts with their neighbors, their family, caregivers, and that type of thing. So it's a nice tool. What have I forgot? What have I forgot if we're talking about overall quality of life? Okay, the one thing let me just do this. All of these now interact with each other. And I think I've given you examples. What have I forgot?
Spiritual, religious.
Okay, that's a part we can't ignore. But me, the dentist, forgot. Oral health. Didn't I just give you a whole spiel before I got into this? See, this is where we forget the impact that oral health has. So actually our diagram becomes a pentagon where oral health is integrated in with all of this. We have enough studies that have been done that demonstrate that many people that are not happy, that have pain in their mouth, and you can imagine how pain, no teeth, oral cancer. Can you imagine the disfigurement that must come across when you have oral cancer or squamous cell carcinoma in the neck? And many of our smokers who inhaled have squamous cell carcinoma in their neck. If you've ever seen a patient that has had that surgery, it's a very debilitating surgery. It disfigures them. It really disfigures them. And they require a lot of physical therapy. They require a lot of reconstructive surgery, a lot of counseling and guidance. But if we take a look at our overall picture, we've looked at oral health. Now, let me take a little time and see if I can get some questions that can maybe specifically hone in, since you all come from different fields, in relating to what we've discussed. And it doesn't have to be the dental aspect. It could be this quality of life aspect. Are there any questions? Yes, ma'am.